Good morning, and welcome to today's Grand Rounds presentation. It's my pleasure to introduce today our speaker, Dr. Katherine Scangos. Katherine is conducting some fascinating cutting-edge research in the area of neuromodulation that I'm very much looking forward to learning more about today. Katherine received her undergraduate degree from Amherst College and went on to get her medical degree as well as her doctorate in neuroscience from Johns Hopkins School of Medicine. She currently is an assistant professor in the Department of Psychiatry at the University of California, San Francisco. There she conducts cutting-edge quantitative circuit-based neuroscience research to identify electrophysiologic biomarkers, not just of mood disorders, but also biomarkers that can be used to personalize delivery of brain stimulation or neuromodulation interventions to relieve symptoms of depression. She is the co-director of the Transcranial Magnetic Stimulation Service, as well as the Neuromodulation Clinic and Research Program at UCSF. She's had some fascinating recent results that have received wide press coverage about personalized treatment of depression using responsive neurostimulation of the brain. And it's partly on the basis of that work that she also now is working as a medical director at Neumora Neurotherapeutics, where she's working to integrate multimodal biomarkers into development of deep brain stimulation techniques for clinical trials on a larger scale. Her work has been widely recognized as being extremely innovative. She's the recipient of the National Institute of Mental Health Outstanding Research Award program and the Trailblazer Award, as well as she's received funding from the Brain and Behavior Research Foundation, the NARSAD Young Investigator Grant, as well as funding from NIH. It's my pleasure to introduce Dr. Scangos and to turn things over to her for her talk. Thank you.
So thank you very much for that kind introduction and the invitation to present some of my recent work. It's unfortunate that we can't be in person this year. But as an overview today, I'll talk about the goal of personalization within depression treatments, the use of neurostimulation to specifically modify dysfunctional neural circuit activity, and a clinical trial that we're running at UCSF that's designed to test the feasibility of personalized closed-loop deep brain stimulation. So here are my disclosures. I recently started working with a company called Neumora. And here are the 3 learning objectives. So 1 is state 3 approaches for personalized deep brain stimulation. 2, identify 3 important properties of stimulation response, understand the concept of closed loop control, and understand how spectral and network features can be integrated to identify individual depression subnetworks. So depression is a very common condition, as everyone here is aware, with a prevalence of 300 million people worldwide. And it's really one of the leading causes of disabilities. And while many people can be managed with behavioral therapy or pharmacotherapy, there's a cohort of people who are resistant to all current standards of care. And the poor response rate may be due to the etiological and diagnostic heterogeneity of depression. So numerous studies suggest that depression may be related to alterations in a variety of biological systems shown here. And it's not likely to be one single disorder. And this is the idea behind NIH RDoC criteria to develop a research framework for investigating mental disorders that integrate many levels of information to explore basic dimensions of functioning rather than the disorders themselves. So anhedonia, dysphoria, cognitive dysfunction. And novel technologies such as cortical or deep brain stimulation are focused on circuit dysfunction models of depression and are a potential solution for patients that are resistant to all available therapies, particularly because symptom dimensions can be mapped to dysfunctional circuits and then specifically targeted. So intracranial brain stimulation, such as deep brain stimulation, has shown promise as a treatment for refractory depression. So in this treatment, a pulse generator is either surgically planted in the chest or the skull, and it delivers stimulation through implanted electrodes to one area of the brain. It typically targets just one area, single structure in every subject, and delivers largely fixed and constant stimulation dosing. And the approach has been very successful in Parkinson's disease and epilepsy. It emerged as a treatment for depression in 2003, led by the pioneering work of Helen Mayberg. And in open label trials, patients even with the most severe depression achieved remission. And there was a great deal of excitement because it was one of the first treatments that targeted specific brain circuits. But unfortunately, results were not consistently replicated across 3 randomized clinical trials. And the figure here on the right shows a trial of ventral capsule stimulation where efficacy was assessed at the 16-week time point. So you can see the lack of difference between the active and control conditions in the figure, and that may be due to the trial design. There's some thought that the 16-week time point may have been, in retrospect, too early, too short, but inter-individual response heterogeneity also likely played a role. And so this suggests rather than abandon deep brain stimulation, novel strategies are needed. So personalization of therapy is proposed as a means to improve outcomes in medicine generally. So the variable presentation of symptoms across individuals of depression is evidence that different neural circuits may underlie different depression biotypes, and speaks to the need for personalization in therapy in psychiatry as well. So in this image from Leanne Williams' work that many of you, I'm sure, have seen, she highlights specific circuits underlying specific symptoms of depression and suggests that knowing the neural circuit involved for each patient might inform clinical decisions for them. So we argue that that same type of personalization is also needed in brain stimulation. And in fact, multiple anatomical structures are now being targeted for DBS and have shown promise in small studies. So this includes the areas that are well known, such as the subgenual cingulate and the ventral capsule, but now other areas in the reward circuitry as well, and the OFC and other regions. And so the fact that stimulation at multiple sites can improve symptoms in different sets of people suggests that personalization of brain stimulation is possible. So I'll talk briefly of the 2 most common DBS targets. The majority of work has been done on the subgenual cingulate by Helen Mayberg, which is built on the corticolimbic dysregulation hypothesis of depression. And in this model, she thinks of depression as the net effect of failed network regulation, which can be modulated at different nodes along that circuit. And she identified the subgenual cingulate as a key node that addressed what she perceives as the core symptom of depression, dysphoria. And she found that there was increased blood flow in the subgenual cingulate and either induced sadness in healthy subjects or depressed subjects, and that this overall activity in the region improved as depression resolved, either with successful treatment with antidepressants or with DBS. And she's now gone on to optimize targeting within this region. She's identified a particular area of the subgenual cingulate using DTI and the patient's own anatomy, the intersection of these 3 white matter tracts shown here. And found that if the stimulation is delivered right at that location, it leads to the best outcome. The second structure that's been most commonly utilized is the ventral capsule region. This is part of the reward pathway and targets another key symptom, anhedonia. And it's a region that was first targeted for treatment of OCD and obsessive compulsive disorder with capsulotomy and then deep brain stimulation. And it was found to reduce the depressive symptoms in these patients as well. And so it was used as a target for depression itself. A second strategy for personalization that's being used is done by Samir Sheth's group. And so they implant DBS leads in the ventral capsule and the subgenual cingulate, as well as temporary electrodes in additional brain regions to explore the large set of stimulation parameter potential. So they vary stimulation, intensity, frequency, pulse width, polarity. They're using current steering to look at the volume of tissue activation. And so this means that once a patient begins DBS therapy, the parameters have already been explored in an automated fashion. And this is another means for personalizing treatment. So here's a comparison of these 3 trials that are currently underway, working towards the goal of personalization. Helen Mayberg's using DTI to identify individualized targets in the subgenual cingulate. Samir Sheth's study happening here, in part where they are using advanced current steering methods and automated approaches for identifying optimal stimulation parameters. And then our study that's targeting different locations to identify personalized locations for stimulation, but also to identify sensing sites to implement closed loop stimulation. And that's what I'll talk about now. So in deep brain stimulation, traditionally electrodes can only deliver stimulation, but can't sense neural activity. So there's really no way to read out the effect that stimulation has on the circuit that you're targeting. It's also possible, though, to implant microelectrode arrays or leads that can continuously record neural activity. And that's what's being shown here in a patient with spinal cord injury who has an array implanted in the motor cortex and one that senses neural activity. And when one particular pattern is observed, it can move this experimental arm, or more recently, a patient's own arm. And so you can see from this that personalization of therapy not only includes where you stimulate in the brain, but also when you stimulate, right? You don't want this arm to be moving at all times. You want it to be moving only when you need a drink. But with the motor system disorders, you have visual feedback, right? You see the arm is moving, or a tremor of Parkinson's disease is reduced. But in depression, you can't necessarily visualize an emotion or a thought. You have to rely on subject or physician reports of symptom severity state at each moment in time. But the same principles can apply. So with the addition of neural sensing, a patient's own physiological activity can selectively trigger stimulation when a pathologic state is detected. And then you can read out the effect that stimulation has had on the circuit that you're targeting. And so that's the idea behind closed loop deep brain stimulation. Treatment is delivered only when symptom severity is high, which may reduce side effects, prevent adaptation, and improve efficacy. And there are a couple of devices on the market that have the capability to continuously sense neural activity. I'm showing here on the right the FDA approved and commercially available NeuroPace RNS system, which is the one that we are using. Medtronic also has one now that is clinically available and is being used in OCD and in Parkinson's disease primarily. So the biggest challenge for closed loop deep brain stimulation in psychiatric disorders is finding a symptom-specific neural biomarker that can trigger stimulation. And that's something that had not previously been found for depression and is the major limitation. Potential was, at the time we started, was the major potential limitation. If we couldn't find a biomarker, you can't deliver closed loop stimulation. So to address this, direct neural recordings and focal electrical stimulation have been used in the pre-surgical evaluation of patients with epilepsy in order to identify each individual seizure focus and map out important functions that need to be spared, such as language or motor control. And these electrodes are left in place typically for about a week while patients remain in the hospital. And we thought that this similar type of mapping stage could also enable personalization for psychiatric disorders. And so now we have trials at UCSF for depression, but also chronic pain and OCD, with the idea that we can extensively map corticolimbic activity. So this means look all across the circuit and see what effect stimulation has. And then also find a biomarker of a high symptom severity state that could be then implemented into closed loop treatment with one of the chronic devices. And the idea behind this goal were developed from years of research through a DARPA subnets program led by Edward Chang at UCSF. And I came to UCSF as a fellow to work on this project and then stayed on as a faculty member to lead this depression trial. And in this research from the subnets project, emotion circuitry was mapped out in patients with epilepsy to identify novel stimulation targets. And then biomarkers of anxiety and depression were also investigated. And so here I'm showing some of the work using intracranial recordings across 54 subjects and patients who had epilepsy and comorbid depression to identify spectral activity features and connectivity features that were predictive of depression. So this approach consisted of two steps: a model building step where we identified large-scale functional networks across IAG electrodes, and then a model utilization step where we related the architecture and intrinsic neural activity of these functional networks to depression status. We further identified two clusters of subjects with depression that express different neurophysiological activity and connectivity patterns, and that's what's shown here on the bottom right. And so we think, potentially these results could be utilized in the future, decide on a treatment target, and we're now using non-invasive modalities to help us identify correlates of these biotypes. And building on the subnet's work, we designed a clinical trial to test the potential efficacy and safety of personalized closed-loop neurostimulation for major depression. So the goal was to perform this mapping stage that I showed you in patients with primary depression, and then implement closed-loop neurostimulation with the NeuroPace RNS system. The trial is called the Presidio trial. And in the first stage, we implant 10 temporary 16 contact electrodes to map out personalized stimulation and sensing targets and begin to identify the neural biomarker of each patient's symptoms. And in the second stage, the biomarker is integrated into closed loop therapy with the NeuroPace system. And in the third stage, we perform a randomized controlled study of initial efficacy and feasibility. So here's our study population. It focuses on patients who have treatment-resistant depression. The major inclusion criteria that have been different from prior studies include evidence that neural circuitry can be modulated, as evidenced by a response to ECT, but not a sustained response. And two, we required that there is sufficient variability in self-reported symptoms, and this was a requirement to enable biomarker detection. So we had people take home an iPad and rate their symptoms over a number of days, so we could test for that variability. So here's the overall study design. First stage is implementation of the 10 temporary electrodes across 10 different brain locations within the corticolimbic circuitry. So then we have 10 days, and over the course of those 10 days, the patients stay in the hospital or a laboratory setting where we conduct the stimulus response mapping. And the goal there is to identify the target where stimulation best improves depression symptom severity. And then we also pair resting state neural activity that's recorded continuously during those 10 days with clinical depression scales to identify spectral biomarkers of the high symptom state or high symptom burden. If we're able to find a brain site where stimulation leads to a consistent change in clinical symptoms, participants meet criteria then to move on to stage 2. And in stage 2, the NeuroPace device is implanted with 2 4-contact leads placed in the locations identified in the first stage. And then we have up to a year to validate individual biomarkers and identify stimulation parameters that both modulate depression severity and shift the biomarker to a healthy state. So when subjects receive a 50% improvement on a validated depression rating scale, we're using the MADRS here, or a year has passed, then they qualify to move on to stage 3. And in stage 3, that's the core study period. We look both at the short and long-term efficacy of the treatment, and it follows a crossover design with an intervening 6 months treatment period. And again, our primary outcome is a change in MADRS score across the first and second 6-week crossover periods. And we've now completed stages 1 and 2 in a few subjects. We're in the middle of stage 2 in a couple subjects, and we've completed stages 1 and 2 and part of 3 in our first subject. So in this set of slides in the rest of the presentation, I'll discuss our results from the first pilot patient whose depression remitted with this type of closed loop stimulation. So here I'm showing the results of the 10-day clinical mapping study. So during this time, we performed bipolar stimulation survey across the electrodes in the ventral capsule, subgenual cingulate, hippocampus, amygdala, and orbital frontal cortex bilaterally. And it was pretty amazing. We saw a diversity of very specific responses across the different sites and stimulation parameters. We were delivering about 90 seconds of stimulation, and she would report how she felt. So some examples of this included tingles of pleasure with 100 hertz stimulation in the ventral capsule, or neutral alertness, less cotton and cobwebs with 100 hertz stimulation in subgenual cingulate, or a calm pleasure, like she said, reading a good book or being wrapped in a warm cocoon with 1 hertz stimulation in the OFC. And it was really astonishing, the most astonishing thing in my career so far, to see these effects so specifically and really learn the roadmap to her brain to the point that I could predict the resulting emotion or mood state that would be elicited prior to stimulation. And I think it was an incredible experience for the patient as well, who had really been stuck in one state for so long. So the ability to suddenly feel relief was just really encouraging to her, and also helped her feel better about herself and release some of the stigma that she herself felt towards her own depression. So after performing this stimulation, we then further explored the brain sites and stimulation parameters that elicited a positive response with sham-controlled stimulation. So now she didn't know when we were stimulating or where we were stimulating. And we assessed the effect of the stimulation using a couple of different clinical measures. We used a 5-point Likert scale combining subjective responses with physician-rated affect, visual analog scales of depression, anxiety, and energy, and a 6-question subscale of the HAM-D17 to assess short-term changes in depression severity. So results from these scales suggested that stimulation largely modified 2 dimensions, the arousal and the mood valence dimensions in this particular patient. And 3 stimulation paradigms all reliably improved mood, but were associated with different effects on the level of her activation. So 2 of the paradigms, 100 hertz stimulation of subgenual cingulate and the ventral capsule, were consistent with prior DBS studies. And the third was a novel location and stimulation condition, low frequency stimulation across a broad region of the orbital frontal cortex. So you can see these first 3 regions and locations on this chart here. The responses to stimulation at these sites were also consistent across trials. So ventral capsule and subgenual cingulate were consistently activating. That's shown here in the red and the blue. And the OFC was consistently sedating. However, the effect they had on the mood was state dependent. So that's what's shown in these yellow and blue plots. For example, in the orbital frontal cortex, the effect of stimulation was positive and calming if it was delivered during a high or neutral arousal state, but worsened her mood if it was delivered in a low arousal state, causing her to feel excessively tired and drowsy and uncomfortable. And the opposite pattern was observed in the subgenual cingulate in the ventral capsule regions where stimulation increased arousal. So the effect of the stimulation was state dependent. This patient's primary symptom of her depression was anhedonia. So she perceived the most consistent benefit from stimulation in one region of the ventral capsule, areas of an area of the reward circuitry. So we also found that the response to stimulation was dose dependent, as shown here for the ventral capsule stimulation, on both the mood and arousal dimensions for 1, 2, and 3 milliamps. And we found that the response to stimulation was also sustained beyond the stimulation period itself, even up to 40 minutes for the ventral capsule shown here. And the results altogether, the dose dependence, the persistence, and the state dependence together suggest to us that closed loop stimulation is feasible treatment option that was worth further exploration and may even be necessary for some people. So in addition to the clinical mapping, we also did biomarker exploration during this period. So we had the patient perform 335 visual analog scales of depression and anxiety over the 10 days, which we used to define 2 symptom severity states, a low and a high state. And we identified the 15 minutes of resting state activity that coincided with the clinical measures where one of these 2 states was present. That's this red state and the blue state. We then identified the intracranial spectral activity features that discriminated this high and low symptom states using 2 different cross-validated supervised machine learning models of different spatial resolutions. So in the first model, shown here on the top right, the spectral power was averaged across all contacts within brain regions. So we had 60 total features, and we found that gamma power in the bilateral amygdala, OFC, left subgenual and right hippocampus all had high state discriminative potential. In the second model, the feature set was defined by spectral power for each electrode contact, which allowed us to then account for the intra-regional variability due to electrode positioning. And in this model, we found bilateral amygdala power alone, gamma power alone, was sufficient for detecting the high symptom severity state. So we were surprised that this biomarker could be as simple as this, but the findings suggested that amygdala gamma power is a biomarker of the highly depressed state in this individual. So we found that ventral capsule was the brain site where stimulation led to consistent improvement in symptoms, and amygdala was the site of the biomarker activity. So we next wanted to examine connectivity across the cortical limbic network to determine whether these 2 nodes, the VCVS and the amygdala nodes, constituted a structurally and functionally connected subnetwork. So with the idea that ventral capsule stimulation would directly influence the amygdala biomarker activity. And this could provide further justification that selection of these sites for the chronic placement of the stim and sensing leads. So to examine effective network connectivity, we used EP mapping. So we delivered single pulses in one region and looked at the evoked potential in the distal contacts. And we looked at the N1 and N2 peak deflection magnitudes using standard approaches. And here I'm showing the directed graph for N1, where the percent circumference for each color indicates the strength of connection between any 2 brain regions. And the color itself indicates the starting location. So this is the ventral capsule stimulation projecting to the hippocampus. So the connectivity strength and direction were then quantified by calculating the weighted in degree, which is the sum of significant connections pointed towards a node. And we calculated the out degree, which is the weighted sum of connections pointing away from a node, in order to identify the most influential hubs in the network. And we found that ventral capsule itself had the highest weighted out degree, suggesting It has strong connections to other brain regions, and the amygdala and hippocampus had the highest weighted in degree, suggesting they receive connections from many other brain regions. And so we felt this was consistent with our choice of a stimulation site that might influence others and a sensing site that reads information from other places. So that we then examined the axonal fiber tracts that might mediate this effective connectivity using DTI, and we were aided by one of our collaborators, Leo Sugru, in neuroradiology. And we found that there was also dense structural connectivity between the right ventral capsule and the amygdala, comprised of two fiber tracts primarily, the stria terminalis, which terminates in the bed nucleus, and the ansa peduncularis. So, and finally, we found that stimulation at contacts 2-3, that was the location we targeted, led to clinical improvement severity on 11 out of the 14 trials that we tested. And when we looked at the change in gamma power on the trials, we had pre-post VAS scales and resting state EEG activity. We found that the reduction in gamma on both trials where symptom severity improved. And that was absent on trials when symptom severity worsened due to an alternate stimulation paradigm, or when symptom severity remained steady due to minimal symptoms at baseline or a primary increase in energy over depression. So that's what's shown here in red and blue. So in conclusion, we characterized the complex interplay between symptoms, mood state, and neural stimulation, and we demonstrated the importance of a patient's symptom profile in interpreting the clinical response to stimulation. And these results suggest that a time a patient spends in a particular mood state could be a consideration in the selection of a stimulation target. And it also suggests that a biomarker can be identified and that we can identify a limbic subnetwork that both reflects depression severity and can be modulated to decrease clinical symptoms. And this is our approach over here on the right. Identify a stimulation site, identify the sensing site, and then test the interaction between those sites through affective network connectivity, structural connectivity, and then the effect stimulation has one region on the other region. So in stage 2, we implanted the NeuroPace device with 2 separate sensing leads based on the mapping study. So we used DTI in the planning of the surgery so that the contacts interface with those 2 fiber tracts I showed you, the stria terminalis and the ansa peduncularis. And we were able to successfully replicate the location in our second surgery. We then assessed whether we could replicate the clinical effects of the ventral capsule stimulation that we saw in the mapping study. And we found that at the expected contacts based on anatomy, we again saw acute symptom improvement across the majority of trials, which the patient described as pleasurable and energizing, just as in stage 1. And we saw the opposite effect with stimulation in the amygdala. It made her symptoms worse. Furthermore, in closed loop stimulation, in addition to frequency, pulse width, and current amplitude, we also have to consider burst duration as well. So when that pattern is detected, how long will stimulation be delivered? So to do so, we tested the clinical effects of intermittent stimulation at different stimulation burst durations over 15 and 30 minutes. And we found that just 6 seconds of intermittent stimulation at 1 milliamp was clinically effective. And importantly, it was below the patient's perceptual threshold, meaning that she couldn't detect the on-off state. And this was really important to us because we didn't want stimulation to be jolting her all throughout the day and interfere with her normal daily functioning. We also found that we were able to replicate the symptom-specific biomarker for closed loop control. So we used the NeuroPace system telemetry wand to stream ECOG in the lab, and then we recorded 10-minute trials of continuous amygdala activity while the patient engaged in naturalistic activities, This might include such like looking at her social media account, talking to family members on the phone, watching movies, and we even actually had her do her therapy appointments in there while we recorded activity because they were being done on Zoom at that time. So we then paired the neural activity with her clinical severity ratings. And again, we found that amygdala gamma power was highly correlated with both BASD and HAM-D6, and it significantly differentiated the high symptom severity state from the low symptom severity state. So then we implemented closed loop therapy. So we turned it on so that 6 seconds of stimulation would be delivered every time the biomarker was detected. And we found that the number of detections within a 10-minute period also was highly correlated with BASD and HAM-D6 as well. And that's what's shown on the far right. So over 2 months, we analyzed the data. On average, there were 468 detections per day with minimal stimulation per night. The stimulation did interfere with her sleep if it was given late in the evening. So we set a stimulation cap at 300 therapies per day, which usually had the stimulation stop at around 5 p.m. And that's equivalent to 30 minutes of total stimulation per day, which is, as you can see, way less than standard DBS, which is delivered 24/7. And so even with this amount of stimulation alone, we saw a rapid improvement in symptom severity and depression as measured by the MADRS. And we can't really say anything about efficacy because we need randomized controlled trials, but observationally, this subject's MADRS score dropped from a 33 the night before stimulation to a 14 at the first measurement just 12 days later. This is a 58% reduction, and it dropped below 10 remission several months later. And she actually still remains in remission today. We implanted this device in 2019 summer, and she's doing really well, started driving again, living on her own. She's taking computer science classes, learning how to program, and has, a different outlook on life and hope for the future. So to further test whether the closed loop algorithm triggered stimulation in a manner linked to her symptoms and not randomly, we also examined the relationship between a morning symptom severity rating and the daily detection counts over the 2 months. And to do this, we use dynamic time warping to non-linearly align the daily symptom severity and biomarker detection count time traces. So this is shown here in the gray and the purple. And you can see how aligned they are. And we found that fluctuation in daily symptoms was significantly associated with the fluctuation in number of biomarker events detected by the device. And so this suggests that the algorithm detects change in symptom severity significantly better than chance. So in summary, we replicated the effects of the mapping study with the NeuroPace device. The effects of clinical response to ventral capsule stimulation was positive and energizing, and amygdala gamma power was again found to be predictive of symptom severity state. And this is a picture of her at home, doing the neural recordings with the wand and then downloading them onto her device. So we have a lot of work left to do. We don't yet know how variable these findings will be across individuals and whether the short-term response that we're seeing will lead to long-term treatment of major depression, although it's been effective for this particular patient for a while. But the results are encouraging, and the locations of the implants on our subsequent patients are different from our first patient. So this framework is also not unique to depression, but could be applied to a broad range of neuropsychiatric conditions as long as they're circuit-based. So the understanding of circuit activity related to pathologic states and this dose-effect relationship of circuit modulation could also provide knowledge to help in develop of other new treatments. There are many times these relationships are studied in animal models, but it's more difficult in psychiatric disorders because understanding the relationship between circuit function and disease phenotype is sometimes difficult to assess without asking an animal how it's feeling. So these human circuit biomarkers that we're collecting in small patient numbers may allow for back translation to animal models for more extensive testing of the circuits and stimulation responses. And then that can be forward translated into larger populations of human patients again in the future. And we have a collaboration with Stanford to look at some of these questions. And it's really the unprecedented access to the brain that allows us to do this. So the work I presented today is made possible due to the broad collaborative multidisciplinary team, including Eddie Chang, who conceptualized much of the work in this area and led the subnets project. Phil Starr, Ankit Kambadi, Ghassan Makul, and Andrew Crystal. Andrew leads the broader stimulation program in psychiatry department. And collaborators, Vikram Rao in neurology and Leo Sugru in neuroradiology, and of course, our funders as well. So again, thank you so much for the invitation today, and I'm happy to take questions.
Thank you very much, Katherine. That was a terrific talk. I'm sure there are going to be a number of questions coming in here from the audience, and I would invite anybody who wants to ask a question to go ahead and put it into the chat or the Q&A box, and we'll get to them. I'll start things off, Katherine, with a question about some of your closing comments. You said that there is some target variability that you've already seen in your subsequent subjects. Can you talk a little bit about what those other target areas are looking like and just how variable they are?
Sure. So as you know, we're targeting 5 different regions on each side of the brain, right? There's the ventral capsule, subgenital cingulate, and OFC. And so our thought is that those are going to be the best stimulation targets potentially. And then we have two other areas, but really 3 sensing potential sites that we anticipated, the amygdala, hippocampus, and then we thought the OFC might be a good sensing site as well. What we're finding in our second subject is we actually implanted at the subgenital cingulate, and then we found a biomarker that we're re-exploring in stage 2 now in the OFC. And our third subject, we implanted in the nucleus accumbens and the subgenital cingulate. So they're different, overlapping. And we found a biomarker in the subgenital cingulate for the third person, which we weren't sure we would be able to do. So that's 3 people. We have 3 different subnetworks that we've identified. We're hoping that we won't have something unique necessarily in every patient, but we'll have some groupings of patients that seem to do better with stimulation in certain areas based on their symptom profile, so that in the future we don't have to do this exploratory stage and we can predict where their biomarker and stimulation site might lie.
Right. Okay. Very interesting. So how broadly can you sample for sensing, just in terms of what the technology is capable of? And how broadly can you stimulate? How many different target areas are you capable of examining the potential of using the technology as it now exists?
Yeah, with the chronic devices, not very many. And that's why we needed that first stage. So we have only 2 leads with the chronic device, the NeuroPace device. One that they can both stimulate and sense both leads, but not at the same time. So we have to have, we can't stimulate in 2 different locations, for example, which would be nice if we could target 2 circuits, right, and deliver treatment to 2 areas. And we can only identify 1 biomarker at a time. So it is a little bit limited in terms of the technology. And the same is true with the Medtronic device. You have to choose a single location to stimulate and, 1 biomarker. You can choose at one time. So if you wanted the patient to come back in, you could switch to another stimulation location and a different biomarker at a different time. But at one time, you can only stimulate and record in one location.
Right.
Yeah.
Okay, great. Thank you.
Mhm.
So we have one question from the audience here, which is, what happens to the frequency of biomarker um, activity, detection, and stimulation over time? That is there any sort of neuroadaptation? Similarly, do other biomarkers emerge once the biomarker has been used for stimulation, treated for a while?
Yeah, so that's a really great question and something we're very interested in. We don't have definitive answers yet, just because we don't, we have only one subject who's done a lot of stage 2, who's been treated with stage 2. The other 2 patients were still exploring the best biomarker and stimulation sites. But I will say that the gamma biomarker has held up all this time, and it's been quite a while. We implanted in 2019 summer. And so we anticipated that it maybe there would be plasticity and, we wouldn't need to stimulate in the same circuit, or the biomarker might resolve and it wouldn't be useful anymore. But that hasn't happened. So we do know that she has fewer detections per day on average than she did at the beginning. But she still is getting a lot of detections and stimulation throughout the day. So it's only gone down, a little bit. That could mean there isn't plasticity and she'll need this long term, or it could mean that it takes just a really long time. But thankfully for her, it's still working.
Right.
Yeah. And then that's a question we'll be able to answer as time goes on. We do have them come back and we do reassess and have the opportunity between the 2 6-week crossover periods to modify the biomarker, because we thought you might need to make some biomarker modifications for sensitivity. That hasn't panned out. We haven't needed to yet.
Right.
Mhm.
Right. One question a little bit off the topic, Katherine, but all of the biomarker or the major biomarker work that you're talking about now is invasive. I wonder if there is the potential prior to surgery to do some exploratory work. Number one, to see whether somebody is a candidate for this kind of deep brain stimulation. And then secondly, perhaps to narrow down the field of potential candidate sites so that you would perhaps, using a non-invasive technique, be able to say, okay, we want to focus on this particular circuit in this individual.
Yes, we definitely agree. And ideally that would take over from this more invasive exploratory stage altogether. Like you could do that whole stage non-invasively. We are starting to do some research to look at EEG and MRI equivalents of these amygdala biomarker that we could then target potentially with TMS if it requires stimulation in OFC or some of the more cortical structures. So it's possible that we could find these correlates. And so we were starting with imaging to see if we could find some type of correlate in that manner. But you're exactly right. That would be the goal. There's an OCD trial ongoing at UCSF and Stanford collaboratively, and they are doing that in OCD. They're trying to use TMS to explore different targets together with imaging.
Oh, okay.
Well.
Interesting. Great.
Yeah.
We have another question here specifically about state dependence of biomarker. That is, how do you, excuse me, how do you control for state dependence when the patient is in stage 2 or using the device in daily life in a more uncontrolled setting?
Yeah, so I'm not sure what's meant exactly by control for state dependence, but the biomarker should be representative of a particular state. I mean, that's the goal of the biomarker. So, in stage 2, when the patient's at home, ideally it should be detecting when a patient is in this negative mood state, and that's when stimulation is delivered. So I'm not sure if you mean scientifically control for it, or if you mean stimulate only when someone's in a negative state. We had the patient come into the lab for long periods of time, days, like whole days at a time, and engage in regular activities, which we hoped would mimic what she did at home. So we had her, call her dad, who was something she does frequently that is upsetting to her. They have a complicated relationship. So we had her do that in the lab while we recorded. She did her therapy appointments in there while we recorded. We had her go eat lunch, and we look at her Facebook posts and her dog pictures and watch Bones. That was a movie that was upsetting to her, where we saw a lot of detections anytime gruesome scenes came on. We also played around with targeting her personality structure, and so we would have we had a couple sessions where we had certain conversations that we thought would put her in certain states to check to see if the biomarker did in fact detect when she was in this distressed state, and that that worked as well. We saw the biomarker being detected right when we made certain comments that we thought might trigger her. So we did try to put her into as naturalistic a setting as possible once she's in stage 2. And she helped us a lot with identifying triggers for her, or situations that might lead to a downward spiraling and ruminative thoughts. So that's what we did experimentally to try to mimic the real world.
Okay.
Mm-hmm.
Related to the real world measures and outcome, we have a
Mm-hmm.
couple of questions about what other measures, what other symptoms may have changed. Did the subject lose weight over time? Was she exercising more? Did her functional status improve?
Mm-hmm. Yeah, so this was a patient who was really not engaged in her life at all when we first met her. She actually was very high functioning at one point of her life. She had very good jobs. She was in charge of she did like the EMR systems, and she had, she was in a leadership position. So she was very functional at one point. But for the last few years, she had not worked. She was living with her parents again. She had stopped driving altogether because driving was related to one of her suicide attempts. So she was really not functioning at all. And now she's been in remission for a long time. She's taking computer programming classes. She moved out of her parents' house. She's driving again. So all of those things reversed. She gets up out of bed and does gardening. So she has she has hobbies. She's working towards employment. She's much more independent. So a lot of these sort of behavioral and life changes have occurred as she's gotten better.
Okay,
Mm-hmm.
great.
Yeah.
We have another question here. Is there a plan to assess whether or not the RNS system can function independently as a treatment for depression, or if it enhances other therapies such as psychotherapy or medications?
I think this is always a treatment in context with other treatments as well. So I don't think this will replace her therapy or her other medications. It's something that adds on. And I think what she's noticed and reported to me is that when the stimulation goes off, it can disrupt sort of her ruminative, very negative thought process. And she has what she says feels like a sense that she has improved cognition for a second, and she can rationalize the situation cognitively and think through this. And then that sort of, she makes choices and she can move on from an incident that might occur. And so she's felt like she, for the first time, can apply some of the CBT techniques she learned. And she said before she could never sort of get herself to do any of those things, or she heard what her therapist said, but she couldn't apply them. And so once she's receiving the stimulation, she's able to apply those techniques. And her therapist was pretty impressed as well. So I think therapy is always going to be very critical for a patient. This sort of is a tool to help them get out of this really negative state so they can function better in their life, apply tools, teach themselves new ways to handle situations.
Right. Makes sense. Makes sense. We have another question here that kind of dives down into the neuroanatomy of the circuitry a bit more. Regarding the amygdala, is there a particular nucleus or group of nuclei that you focus on given their diverse functionality and connectivity?
Yeah, so we had electrodes because, each of the electrodes is in the first stage is 16 contacts. So we have to decide a path, but you can cover quite a bit of the amygdala. And then we can test each of those contacts within there. So the area where the biomarker was detected is the basolateral area of the amygdala that hit those two tracks I mentioned in the talk, the stria terminalis and the ansa peduncularis, those two tracks, which are where they connect up, and then it through the ansa peduncularis, it will go around to the bed nucleus. And so that's the area of the amygdala. It's the basolateral, and we made sure we hit it again when we put in the chronic device, and we were able to get that right location. I think we're a little bit lucky the first time because we do have to decide on a trajectory for the amygdala lead, and we were lucky in some sense to hit that right important area.
Yeah, yeah. I mean, and I think that is an important point. It's clear from your work and Paul Holzheimer's work, Helen Mayberg's work, that precision in the neuroanatomy is vital for these things to work. Related to that, we have a question that I think touches on this. That is, what should we make of sham-controlled DBS studies that in depression that have shown no difference between control groups and active treatment groups?
Yeah, so that's what has happened, right? There have been a couple of 3 trials that have been negative, and they showed no difference at the end of the treatment or sham period. And so that was really concerning. I think it's in the DBS community, and it suggests either that, DBS is not working at all, and it's just all sham or placebo, or, it can suggest that we need new tools and new techniques. And so that's the angle that I think we're trying to take, and different groups are trying to pursue in different ways. So for us, we think that, maybe DBS is effective some of the time, but it's not, it has the opposite effect when people are in a different state. And so it can cancel out, right? Or it could even be negative. And that's why this closed loop is so important, because it's important to stimulate only when someone's in a good state. And then, Samir Sheth's group is really working on the parameter space and understanding where the current is and which tracks it's hitting, and exploring that area further. And then Helen Mayberg's working on personalizing and targeting into those certain white matter tracks for each individual, and identifying biomarkers of the right target location. So, there's been a lot of discussion about why those trials are negative. Is it the heterogeneity across populations? Is it just total placebo and it will never be effective? Is the time course too short? So that the study I showed there was a 16-week time point, and a lot of the findings of Helen Mayberg have been that it can take up to a year to start working. And so if you look after just a few months, you might not see an effect. So I think there are a lot of questions, but it's important to be, careful as we proceed.
Yeah. Okay, great. Well, we are about out of time here, Katherine. Thank you for a great discussion here, and a terrific talk. It's exciting work, and we look forward to seeing how it develops, and when the pandemic is under better control, hosting you live at UCLA.
Yeah, that would be really nice. It's unfortunate that I couldn't come, but I really appreciate the invitation. It's been great.
Well, thanks so much. You take care. And thanks to everybody for attending today. Bye-bye.
Yeah, thank you. And thanks for the great questions.